Is it good? Okay, so welcome to this, I think, outstanding panel and to discuss really critical issues in global health. And I think based on the i-STARC network, we can really try our best to bring really discussions into the clinical steps. I think it was, one of the dialogues we had from the previous meetings. And I think, and only to give a feeling, I just had a meeting some days ago with the Charité Global Health Center, and I told them our vision should be that if a doctor touch a patient, independent where she or is, the awareness that this intervention, even as diagnostics, even as a treatment or cancer care, should be reflected in a global health issue, from the microcosmos to the macrocosmos. I think this is even the red line and the backbone what Zaranasa is coordinating and initiating here. So it's my pleasure. I'm today not in the hospital. I've been in the hospital, but now in the headquarters of the Cancer Society of the Nogo, who is even a strong collaborator of this wonderful network. So let's grow up in our family. Thank you.
Thank you very much, Professor Sehuli, for starting this meeting with such wonderful words. And these were also the words that always motivate me, that the moment we are with the patient and are present with the patient, this is where global health also takes place. So thank you very much. And thank you to all our panelists who are live here and who will give talks later on throughout the program. Thank you to the participants and to the i-STARC community. And without further ado, I would like to start my presentation. I want to introduce the i-STARC community because we have a lot of new members who are participating in this webinar today. So I would like to take a few minutes to introduce the i-STARC project and the community. And then I would like to start with the topic of global health, what it is and why it's important within the context of women's cancers. Throughout the webinar, you can put in your questions in the chat function, so please do make use of it. We will go through the questions later on. And also we will send you the links to register to i-STARC and to register for future webinars. So please watch the chat space. So I will just share my screen. Okay, great. So this webinar series is part of the i-STARC project. The i-STARC is the digitally supported Trans-African quality assurance and capacity building network for the clinical care of women with gynecological malignancies. And it is a partnership project with the Charité. I'll just try and move my slides. Right, there you go. So it's a clinical partnership project, and it's between Charité Hospital in Berlin and the Bamako Hospital in Mali and the Mohammed VI University in Casablanca in Morocco. It is supported and funded by the GIZ, which is the German Society for International Cooperation, and it is also supported by Siemens Healthineers. The main aims of the i-STARC project as a whole are really to establish a digital health network between gynae cancer centers in Germany and the sub-Saharan region, and to bring research and clinical and educational activities into one single framework, with a particular focus on prevention, diagnosis, and treatment of ovarian and cervical cancer. As I said, it's a clinical partnership. These are the partners: the Charité in Berlin, the Hôpital Gabriel Touré in Bamako in Mali, and the Mohammed VI University in Casablanca, Morocco. The supporting partners are Siemens Healthineers, the GIZ, and as also Professor Sehuli has mentioned, the German Cancer Society, the NOGO, and the Pan-Arabian Research Society for Gynae Oncology. The three main advantages of this i-STARC project are monthly tumor boards, the webinars, today being one of them, and the summer school. The monthly tumor board happens once a month on the last Thursday of each month, and there is a certificate provided at the end of the project. And these are an opportunity for the partners to present cases that they're seeing locally and to discuss with experts worldwide, which we provide. It is also a chance to give didactic lectures and seek second opinions. The second thing that i-STARC does is the webinars. So this is our second webinar. Our first webinar was on breast cancer, and this webinar looks at the topic of global health, which is actually a very important topic and something that we've been discussing over the month of May quite a lot. We also have other webinars planned, and you will see all of those webinars if you register to i-STARC. And if you register to i-STARC, and sorry, my screen has just gone. How do I get back? Are you still seeing my screen? Sorry.
No, it's just gray.
Ja. Kann mir mal jemand ganz kurz helfen?
Machen wir kurz Dings beenden.
So, okay, 2 seconds. Sorry, I just need to reshare. But I can't see I'm sharing. Wait a minute. Ich sehe mein Screen leider nicht. Apologies, 2 seconds. My screen has just disappeared. Ganz kurz Hilfe bitte. So. Hier, hier. Okay, there you go. Okay. So yes, there's other webinars that are planned, and if you register to i-STARC, you will automatically receive notifications and our newsletter to attend these webinars. One of the amazing things about i-STARC is the Pep Connection Software, and this is a software that's provided by the Siemens Healthineers Group, and this is really a training platform where we will post all of our webinar videos for you to access after the webinar, and we post our surveys, we can post questions, literature references, and also research publications from other members of the i-STARC community. So this is really an educational platform that you can use to show your own colleagues, trainees, students for training, but also you get to decide what you want to post on this platform. And you will soon in the next week get an invitation to join the platform. This is exclusive for i-STARC members, and it's an amazing educational tool which is provided through our project. All the information is always provided in English, but also in French. The webinars are also translated in French and provided on the Pep Connection Software platform that you can then look at and listen to and read in French as well. So how to keep up to date? Definitely register on the i-STARC page. We will send you the link in the chat. Register for our webinars. You will receive reminders, newsletters, and videos. Engage with our online service. Use the Pep Connection software. And obviously encourage your colleagues to also join locally so that the community can grow. So thank you very much. So this is the i-STARC project. And within today is our second webinar. I want to talk a bit about global health as a general overview before we start the specific talks. So let's start with the definitions. So the first question is, what is health in general? So this is a question to you, to the audience and the participants, just to think about, okay, what is actually health? What's the definition of health? It's a multiple choice question. Please answer. Nobody's going to know who answered what, but it's just to kind of encourage some interaction and some thinking. So is health the absence of disease? Is it being able to run 10 kilometers in 20 minutes? Is it a basic human right? Is it a state of complete physical, mental, and social well-being? You get to choose multiple answers. Okay, we'll just wait a couple of minutes. and then hopefully we find the answers. So most of you answered a state of complete physical, mental, and social well-being, and this is the known definition for health. This is the definition from the WHO. It is also the absence of disease, but it's not merely the absence of disease. And basic human right, this is maybe a bit of a personal opinion, but it is a basic human right to be healthy, to have the state of complete physical, mental, and social well-being. But the most accurate definition is the last sentence, complete physical, mental, and social well-being. Okay, the next question then is, what is global health? So the question should pop up. Coming up, the next question. You can think about it so far. What is global health? So this is the first question. We need the second one. Okay, so what is global health? The health of populations as compared to the health of the individual, an area for study, research, and practice that places a priority on improving access to healthcare and eliminate health inequalities, health issues that transcend national and regional borders, public health. So we'll wait a minute for people to answer the question. Okay. Do we have some results, some answers? All right, then we can see them. So interesting. Nobody said that global health is public health. That's good, because they're different things. Health issues that transcend national and regional borders. Yes, it's part of global health. It does deal with health issues that go beyond the local and national borders, really. It is also the health of populations as compared to the health of individuals. I suppose the most accurate description is really number 2, which is an area of study, research, and practice that places a priority on improving access to healthcare and eliminate health inequalities. But option number 1 and number 3 are also part of global health. Okay, so next. Oh, this is me. Right. Right, so the next slide, hang on. Right. So basically, yes, global health, there is no single standard definition. It does refer to the health of populations, as I said. It transcends national borders. It also looks at health issues which affect world economies and political climate, and it's mainly concerned with the prevention and screening. So looking ahead to predict and prepare for problems. So it looks at social determinants. It takes the social determinants approach. And in fact, there are many things that determine whether an individual or population is healthy. So you have things like age, sex, and constitutional factors, lifestyle factors, but you also have social and community networks. So working environment, education, agriculture, water and sanitation, healthcare services, housing. So medicine alone cannot deal with all the many factors that cause ill health. So the main 3 principal concerns are the global distribution of health and disease and their determinants, the impact globalization has on the health of populations, and global health governance and how the nature of this is changing. And this is a small chart looking at why global health is different from public health. So as you can see, the public health deals mainly with health issues that impact the health of a population of a particular community or nation, whereas global health looks at not just issues that directly impact the health, but also indirectly impact the health and goes beyond national boundaries. Generally also, all global health issues require global cooperations and looks at prevention in populations and clinical care of individuals, and looks at health inequalities and health equities among nations. So just to show you why global health is important. So this was the life expectancy from global, this is GlobalCan data, life expectancy in the 1800s. And as you can see, a lot of it is red on this map, and red generally means anything between 20 and 39. So this was the average life expectancy of the population then. If you look at 2011, then you can see that the colors have changed. So the life expectancy of the population is more between the 70s and 80s. So this is what global health looks at and why this is the case. So what? So why do we need global health? Why is global health important? This is our next question. No, not popping up. Question is coming up.
Yes.
Right. So why is global health important? Because it's a platform for political discussion, because it looks at prevention of disease, because it looks at controlling pandemics, or because it looks at equal access to resources. So we'll wait a few seconds for people to answer the question. You getting some results? Yeah. So yes, so prevention of disease, it does look at prevention of disease, and this is why it's important. And it's also important because it does look at health inequalities and access to healthcare resources. Obviously, part of it is also that it controls pandemics or aims to control and prevent pandemics. Is it a platform for political discussion? It is, but that's not why it's important, but that's a factor of it. Okay. Exactly. So there is a self-interest. Why? Because global health looks at migration and infectious diseases. And as we said, pandemics and looking at preventing disease and preventing spread of disease. So it gives us some kind of security, human security. It's also important for trade because it looks at the impact of disease, infectious diseases and the spread of diseases on economic growth. And also it looks at social justice. So can people access healthcare resources equally? So there is a moral concern for fellow humans. And women's health is a determinant of global health. And this is why we're talking about this within the context of today. This is the mortality rates, the new GlobalCan data for 2020 for females of all ages for cancer of the cervix. And I'm not going to go too much into this because Dr. Gültekin will talk about cervical cancer in the global health context, but this is one of the things that the WHO is looking to eliminate. And this is why it's so important. Global health as a whole is essential within women's health, because there are things that are a global problem and that are preventable and curable, such as cervical cancer, for example. So the conclusion, we are all responsible and involved in global health, regardless of where we work and what area we work in. Global health issues need to be integrated early into medical curricula, and I think this is something that we need to work towards, and there is a scope there for making global health more prominent within the medical school curriculum. And we need to work to form strong, sustainable partnerships between high-income countries and low-income and low and middle-income countries. So thank you very much. I will stop sharing. So we'll leave any discussions towards for the end of the second talk by Dr. Ulrich, and then we'll go into the Q&A session. So unfortunately, Dr. Ulrich had a short notice commitment and is not able to be with us live today, but he has recorded his talk and he will talk on the challenges in multi and interdisciplinary workflows in the global health context. Because as I mentioned, global health is also about forming strong partnerships between high income and low and middle income countries and it's also about global cooperation. So he's going to talk about the challenges in these workflows.
Address some introductory notes. The i-STARC webinar, Global Health, and my contribution focused on global cancer control and its interdisciplinary workflows in global health, relevant to reduce the global cancer burden. I present to you determinants and burden of cancer and trends. I will give you some rationale why multidisciplinary approaches are essential to effectively reduce the cancer burden, and will give you some ideas about current ideas of global, regional, and national efforts in planning implementation or to reduce the cancer burden, and give you some final remarks and further points for discussion. Multidisciplinary approaches to address cancer is based on the understanding of cancer causes, and as they are multiple, we have to address in preventing and controlling cancer several areas. One is the population level, the other is the health system level. We will see there are differences in cancer incidence and mortality related to income, to culture, to gender, social environment, exposure to risk factors, education, employment, and workforce. So it's a myriad of causes which can be addressed, and we need already, when we talk about prevention, a vast area of specialities and specialists to do effective cancer prevention. With regard to control, it's all about health system strengthening and primary health care, secondary health care, and tertiary care. So what is the global picture of cancer control? When I started to work for WHO as the cancer control focal point in 2001, we had 10 million new cancer cases worldwide and 4 million deaths. In the meantime, almost 2 decades later, the global cancer burden has increased substantially. We are now observing 14 million new cancer cases and 8 million deaths. And 2/3 of cases and deaths are in low and middle income countries. This is a huge global health challenge. In terms of cancer types of global relevance, in men it's lung, prostate, and colorectal, and in our context it's breast, cervical, and then other cancer types are very important among women. I will give you now some notes about where within the cancer control continuum multidisciplinary approaches are essential. We're talking about National Cancer Control Program as the WHO paradigm for reducing incidence and mortality. This is the framework which was created by WHO in the 90s and further developed over. Building blocks is the framework of WHO, how to develop a healthcare system which is effective, cost-effective, and tailored to the needs of patients. And this applies in particular to cancer control. We include into the building blocks service delivery, everything related to how the system is organized at primary, secondary, tertiary care level, means hospitals, buildings, primary health care facilities. When we talk about health workforce and training for cancer control at all levels of care, and this is where we are now operating at this i-STARC i-STARC webinar is about training of specialized and non-specialized healthcare provider to be best prepared to deal with all the myriad of early detection and treatment of cancer patients. We also have to make sure that medical products, devices, medicines, treatment facilities like surgery, surgery theaters, and radiotherapy machines are available to all women and all cancer patients in need. Or the system requires a solid and sustainable financing and governance. And what is extremely important is also the monitoring component of the effectiveness of the interventions in all other areas, in particular prevention, in early detection, in treatment, and palliative care. I will talk now about solutions at national level, how global strategies of the World Health Organization have implication to national planning and how international partners can help. The framework for action is within 3 columns of areas of concern. We need to know the burden of cancer better through cancer registration and the risk factors. This all requires multidisciplinary knowledge of epidemiologists, cancer registrars, mapping of exposure to HPV, to risk factors, to tobacco. In prevention, we need to find strategies in primary prevention, as already mentioned, national strategies to limit the exposure and change behavior towards healthy behavior and more health education. And thirdly, cancer control has to do with strengthening health systems. The good news is that over the last 2 decades, in the last decade, cancer control was increasingly on a very high political agenda. When I talk about political agenda, is the World Health Assembly. All member states of WHO come together every year to the World Health Assembly, as this year, unfortunately only virtually, but in general it's in physical presence in Geneva, and they discuss and debate and agree. 185 member states agree on resolutions, and then they are committed, these delegation of countries, to do actions in their countries. This in general is a very, very effective principle. So we had in 2014 a high-level meeting at the UN, beyond the World Health Assembly, but the UN in New York. So it means at the political level, where all countries agreed that non-communicable diseases, including cancer, are a threat to the development of the world economy. And as a follow-up, the World Health Assembly, under the leadership of WHO, went through this is where the cancer plan of the country is, and they can, of course, have, when they are involved in government activities or in NGO activities, they can have influence on the implementation of these national cancer plans. It's important to know that this is something which is a common ground between government, NGOs, and population. It is only effective if there is a national debate about how to develop effective prevention and control activities in the country. There's a lot of guidance from WHO, guidelines and tools to implement cancer control, particularly cervical cancer and breast cancer now increasingly. So the tools are there. They just have to be taken into consideration when there is a national planning process. More specifically to gynecology, I have the good news that in 2020, a specific resolution of cervical cancer to end cervical cancer was agreed by all members of WHO. The World Health Assembly was absolutely unanimously agreeing on cervical cancer as a major threat to women's health. And every country in the world is now committed to implement a comprehensive cervical cancer plan, which requires multidisciplinary collaboration. And these days, we have a resolution, hopefully approved in the World Health Assembly 2021 on access to cancer treatment. So that's very, very good news for all people working in this cancer. It's not only WHO helping countries in setting up national cancer control plans. Because of this interdisciplinarity, we have other specialized UN agency work joining WHO in cancer control, like the International Atomic Energy Agency based in Vienna. They provide technical support to develop a national capacity in radiotherapy. UNICEF is the Organization for Child and Adolescents with specific interest to vaccination adolescent girls and other questions related to women's health. UNFPA very similar, and UN Women. So we have three UN agencies: WHO, UNFPA, UN Women, particularly interested in women's health and in women cancer. The Global Fund is interested in cervical cancer because cervical cancer is an AIDS-defining disease, so that they want to implement cervical cancer screening in high-burden HIV countries. So we have synergies with the HIV agenda. Equally, UNITAID, which is encouraging industry to produce devices and medicines for HIV and cancer, which generally is not of major interest in low and middle countries, which is not of the industry. So they encouraging new research and development. In summary, cancer control is facing quite a lot of key challenges. First of all, we have competing health issues in every country. In high-income countries, often is this cardiovascular cancer, because cardiovascular disease is less complex in prevention and management, and it is also in many countries of the world, the burden of cardiovascular disease and stroke is higher than cancer, so it might end up in prioritization and competing cancer versus CVD. So we have to make sure that cancer is respected. Primary prevention versus treatment, and this is also an old debate, or neglecting prevention and investing everything in cancer treatment. This is a problem of high-income countries, but increasingly in low and middle countries, where they set up not comprehensive or overestimate the need of cancer management. And of course, this is of as we are clinicians, major interest is treatment, and we have adequate resources for cancer management. We have to make sure as clinicians that management, early detection and prevention is extremely closely related. So you have to think about it more broadly as public health and cancer specialists, that the prevention and early detection is part of the package. And we have to make sure that we work as a team as healthcare professionals and managers. Low and middle income countries, there's even more urgent competing situations between more infectious diseases and cancer, and we have to make sure that this is, the flag for cancer is high. But the recent resolutions on cancer, in particular cervical cancer, prevent that cancer control is neglected. So we have really good news for cancer control, and we are in the driving seat now if we are using our resources effectively. Education of healthcare providers is a big challenge in low and middle countries. We know that the ratio of specialists per population is extremely low. Surgeons, gynecologists, radiotherapists are very rare in low and middle countries. So we have to make sure that knowledge is increasing, that specialist care, special curricula are tailored to the needs of the opportunities in low and middle countries, so that at the end we have best practices in management of cancer. And the political will and public demand is although it is very high on the agenda, we have to make sure that national governments might change very, very frequently, get on track on global and national cancer control, and look at the international resources to develop effective national cancer control. I would like to thank you very much for your attention and good debate over the meeting. Thank you very much. Bye-bye.
Great.
Okay.
Right, I can talk now, yes. Excellent. So this was a great talk from Dr. Andreas Ulrich. It's a shame he couldn't be here live, but we'll start taking some questions. So any questions you might have, just put on the chat. There is, what's interesting and what we're kind of thinking about is the theme and the topic of global health within the medical school curriculum. And I'd be very interested to hear from our panelists who have many years of experience with projects within the global health context, but also being involved in global health issues, what their opinions are about introducing this subject really very early on in the training of a doctor. Because, for example, for me, we never really were exposed to this topic unless we went into public health or international health within our medical school. And we generally, either you develop an interest in this topic later on in your career, and then you start building your network and reading on it, or maybe through some charity projects, but there's really no standard curriculum within the medical schools that provides information on this really very important topic. So maybe Dr. Andreas Kaufman, you can tell us your opinion. What do you think?
Thank you, Sarah, for this question and giving me the first.
We can't hear you.
No, I switched on. Do you hear me now?
Andreas?
Yeah.
Is he unmuted?
I'm not muted.
We can't hear you, unfortunately. Are you're unmuted?
So, wait.
No, maybe try reconnecting your microphone.
Okay.
Your headset.
But we had talked before.
So whilst Dr. Kaufman is doing this, I'll ask Dr. Gültekin.
Now
better? Oh, they can hear you? All right, okay.
Yes, I was decreasing his voice.
Just Sarah. So may I start to give my opinion? I think, as Professor Huli in the beginning said very emphatically, is that global health is a basic integral part of any medical treatment or intervention. And what we see nowadays is, of course, patients travel around, we have migration, we are exposed to other cultures, and we come in contact with diseases from somewhere else. We see it with the pandemic, it's flooding the world. So this is, we are all, and everyone I can talk for Germany, but everyone is aware that this globe, this planet, is one continuum of contact and of mankind and of health. So we are all responsible for each other. We are all involved in each other's well-being and health. And therefore, yes, I think it is maybe the most basic thing we have to think of when we start training, not only in medical professions, and also in other professions, of course, because we have to adapt. We have to adapt to the different challenges we have. We have to adapt to the apples that come from Chile, bring us the vitamins, you know. This is transport, this is pollution of environment, this is money for the apple pickers, and so on. So everything is connected. And therefore, I think, yes, global health is an integral and basic thing to think of, teach, develop, because we are just in the early days of global health theory, development, connections, and cooperation. I think this summarizes what I think.
It summarizes it beautifully, Dr. Kaufman, and I can hear you now as well again. Amazing. Yes, and I think probably the pandemic has also contributed to this being emphasized even more, that we are all connected and this is a really important issue. What do you think, Dr. Gültekin?
Exactly. The pandemic has teach us lots of things, and I believe actually we are coming together more frequently,
yes,
compared to the pre-COVID area. And I see a post-COVID tsunami on meeting together. And I call my friends as Zoom brothers. We are now there is no blood brothers now, but we are now Zoom brothers from one meeting. Yeah. But the point, Sarah, you included is a brilliant idea. I mean, many ampoules has been already enlightened my brain. Because I'm a professor at the medical faculty of medicine. I mean, and we give lectures. And when I hear the lectures here today, what I see that the medical students are trained just by specialty experts.
Yeah.
So somebody comes and just explains osteoporosis. 3 months later, some other comes and just explains cervical cancer. And then the other comes and maternal deaths, labor, something like that. But there is any lecture I have never seen focusing or targeting directly on the global health, global women health, and many other aspects. So I believe we really need this. When you see any patient, any female patient, what you should have in your mind, which type of problems, and then you should evaluate in a global way. Otherwise, our efforts are just waste of time. For example, you can save the patient from cervical cancer, but the same patient can die, you know, from a labor, from a bleeding, massive hemorrhage. It's a globally evaluation of the health systems. And the second point, what was in my brain is, you know, there are some new departments in ministries. I'm sure in German, in many PARSGO countries, these similar new departments also exist, because first WHO implements this department and then the ministers. For example, in our country, we have a General Directorate of Health Promotion.
Yes.
Well, what they do, they make the rationale to make all the science in a simple lay language, easily understandable by the patients. It's a promotion of the health. But in the reality, they only do social media messages. But this is a department that can work here, health promotion. Another one is health literacy. So you ask regularly to the citizens and learn their knowledge on the cervical cancer, their knowledge on different aspects. But health literacy is also very important. And I see this should be a new department in WHO. Department or General Directorate of Global Health, Global Female Health, evaluating the whole aspects together.
Specifically to females, to the women.
Yeah,
Yes.
yeah, but the main challenge here, the main challenge is really joining the people together.
Yes.
This is in our region, usually we are competitive to each other, doctors and competitive to doctors. So for me, cervical cancer is number one, the big problem. For another one, tobacco. For another one, maternal mortality. So everybody has a seat in these problems. When you join all of them, who should have the necessary funds? Who should have the necessary support? So I think a political general directorate, directing all these problems togetherly is a must. Otherwise, I will work on cervical cancer. The other will work on osteoporosis. The other will work on cardiovascular. But who will unite us? There is, first of all, an urgent lead that will bring us together. That's
absolutely. That's a very, very good point you make, Murat, because the way we see it is everybody has dots and somebody needs to connect those dots to form a unified picture that actually makes sense.
Exactly. Exactly.
Knowing that obviously the resources in the world are limited and need to be distributed.
Exactly.
In a certain way, and this is why global health, because this is always an issue that I thought personally in medical school. Well, why should I look at global health? It's politics anyway. And that, but actually, global politics is important because of that, because resources are limited, and so what we need, some sort of direction, and they come into medicine regardless of whether it's global health or not.
Yeah, this is the main problem. I mean, we need really a political leadershipness and stratifying the resources equally, cost effectively. Otherwise, for me, the success is surviving from cervical cancer.
Yes.
But I don't know, but the same patient dies from breast cancer.
Exactly. It's several issues, and there are a lot of issues. Yes, absolutely.
Yeah.
Thank you very much. So actually, perfect timing, Murat, because you'll be up next with your talk on the challenges in screening, diagnosis, and treatment of cervical cancer within the global health context. So, please,
yes, thank you. Thank you so much, Sarah. I am immediately starting also my presentation, and I hope you can all hear me well and see my slides well. So as you already see from our discussions, we know that when you talk about global health, it is the cervical cancer, nothing else. So anyhow, but this topic is really very important. We have a very nice program starting by November 17 by WHO, cervical cancer elimination. But is it really realistic? Do we have challenges? This is the point that I need to discuss with you tonight, my dear friends. We already know that this cancer is totally a cancer that we know from A to Z, what makes the cervical cancer, how we can prevent it. We have the vaccine, we have different screening opportunities. So it is actually a shame to see that 500,000 new cases of cervical cancer exist in the world, and half of these new cases die due to cervical cancer. This is a cancer that can be totally eradicated. But what is the problem? What is the problem? Nothing happens. Well, for me, still 250,000 of the ladies do die, but I don't think that. Of course, the governments are responsible for this because they did not show the high interest to this topic. But we should also ask ourselves, for example, we could never make the necessary lobbying, necessary advocacy, awareness on cervical cancer when we compare ourselves with the breast cancer experts. This is a totally disease of inequality. You see the numbers in the last 10 years. There is no any progress. Mortality, the number of deaths, the number of new cases. But surely this figure in the below shows you that it is minimally 5 times more lethal disease, 5 times in the low-income countries. Yes, this is a disease of inequalities because it is not only being a cervical cancer, but it is also the risk of die. You see the low-income countries to high-income countries, not only being cancer, which is the incidence, but also the risk of dying from cervical cancer increases in the low-income countries. In some countries, it's almost 10 times more mortality compared to the developed countries, even 50 times you see. Yes, this is a disease of inequalities because if you are from a low or middle income countries, your risk of cancer will not change in the next 20 years. The risk will go higher and higher. Your risk will increase day by day, despite the fact that in the high income countries, the risk does not change a lot. And even in the very developed Europe, you see a very clear east to west shift. We have some countries in the east which cervical cancer incidence already more than 20, but we also have some countries in the same Europe with the incidence less than 5 already eradicated the cervical cancer. All these figures shows the cancer, the risk, and the risk of death also of the cervical cancer is a totally a disease of inequality. Oh, finally we had a global reaction. It's not only actually WHO, but starting by March, European Union, many parliamentarians, we also have a local European response, Europe's Cancer Aid Plan. But anyhow, at the end, we have a program now, and the WHO called all countries to achieve these 3 targets until 2030. If you become successful, then all globally, if all countries can achieve these 3 goals, which is 90% vaccination, 70% screening, and 90% treatment of the detected diseases, then we will very immediately see a 30% reduction in mortality due to cervical cancer. This is so crucial. Just to keep in your mind, even a 1-year delay to achieve these targets will produce extra 300,000 female deaths due to cervical cancer. So now it is time to come together and achieve these 3 goals. But of course, we have some challenges. This is the vaccination, the first thing. Of course, we have the challenges. You see high-income countries, low and middle-income countries. Totally contrast how much vaccination, HPV vaccination you have. Again, in developed countries, it is around 2 to 3 times more. And actually, the male vaccination is almost 0 in the low-income countries. If you look to the global picture of the vaccination in 117 countries, please do not forget, it's only almost 20 countries who have a more than 80% coverage in human papillomavirus vaccination. This is so important. You see the number in lower and middle income countries, less than 5%. Unbelievable inequality. And another big inequality is coming because after this program, the demand for vaccines is increasing very rapidly. And every country now calls the companies for further, and like the COVID situation, you cannot find even HPV vaccines sometimes. And definitely very important inequality again. So in short, in HPV vaccines, we have, of course, many important challenges in cost, availability, inequalities in the healthcare, poor awareness of HPV. We have some myths. We believe that this is an infectious disease and this is already under control. Totally, we have some ignorance and fear of vaccines in the healthcare workers and really underestimating the anti-vaccine influence via social media. So these are the 5 important challenges that needs to be addressed in the developing countries. Screening, similarly, the situation is not so good. See, the coverage rate in low middle income countries is around 20%. Globally, it is in the last 5 years, how many ladies are screened? It's only 30%. Very low numbers. And don't forget, screening is just a process. It is not only a test. I mean, you have to also ask what you did after the screening. If you don't know the follow-up pathway of the patient, this screening will not work. So sometimes I see some countries, we have 80% coverage in screening. It does not matter how much of these ladies do come to follow up after the screening. Of course, for many years, we are using Pap smear. Andreas will give you more details, but we are using this Pap smear for more than 5 decades. And it's around less than 20 countries, again, like the vaccination in the world, who have a successful Pap smear screening program. It's a very problematic because we have organizational problems. You need dedicated cytopathologists. Millions of ladies should be screened, millions of ladies. And in 99%, the Pap smear will be normal. I don't have so much pathologists. This is a totally manpower issue, and it didn't work. In contrast, the newly coming the HPV DNA is objective. You don't need the people. Wherever you go, the results are the same. It's not like the Pap smear. It's automated, centralized. It has a manpower advantage. I did in Turkey 7 million ladies, and I am now in Turkey using only 4 pathologists. And then it has a very good positive predictivity, very good negative predictivity. You can screen every lady in each 5 to 10 years. Remember the WHO program, it includes only 2 HPV DNA. So the HPV DNA is a full advantages. It can be done by the self-test in the blood, in the urine. It can be done by a point of care test, you see. So you just go to the GP and have your result in 3 or 4 hours. Well, at the end, anyhow, this screening has some challenges. Some of them are patient-related. You have more information, more webinars, more training. We have the cancer stigmata. I don't understand, but the ladies do not want to learn that they have a cancer. You have a social-cultural barriers. It's important. If you call a lady too frequently for gynecological examination, they really feel affected psychologically. In some countries, there are some charges for healthcare services. In some countries, screening is paid. In some countries, screening is free, but post-screening diagnostic procedures, you have to pay. And you know, my friend, like the vaccine, we did an estimate that 5 billion HPV tests is needed now globally to have a global 70% screening. Anyhow, the third level, the diagnosis. So after screening, at the end, in the cervical cancer, this lady needs to go to a colposcopy. Well, especially in HPV, the numbers of the colposcopy will increase. Yes, it's a super test, but it is specificity is low. In many ladies, HPV is just a transient infection. So if you stand alone do HPV, you can increase the colposcopy numbers. And very recent studies do show us that the gynecologist's experience in colposcopy is decreasing. Yes, this is unfortunate, but we have to, first of all, see the picture. The sensitivity was around 50 to 80% in the old publications, but now it's decreasing to around 30%. And in Europe and in global, in Africa, in many countries. Really, we don't know how many colposcopy devices we have. How many gynae or gynae oncologists we have who can have a colposcopy certified course? How many of the guys, you know, follow some colposcopy guidelines? There's a quality issue. I don't know your quality, your parameters on the colposcopy, and at the end, in diagnosis, given this low sensitivity, this is a really big challenge for all of us. Some technological advancements is coming up, like this one. This is a Samsung cell phone that's really integrated or planned for Africa or developing countries. You just put into the cervix, and this shows you immediately where to get the biopsy. So we need some technological investments to help the gynecologists to make better colposcopies. So very shortly, in the diagnosis, again, we have lots of challenges, some from the patient and some from the health system. The health system is important because it's fragmented. There is inadequate patient counseling, there is inadequate follow-up. You screen the patient, where she goes. Does she really go to a charity hospital, or does she go to somewhere else? There is really a lack of a well-defined referral pathway. Lack of organizational transportation. So we need a system who should follow all these ladies. And from the patient side, of course, again, the long waiting time for diagnostic results, the fear, concerns, I cannot understand, but the patient, the females do not want to face with a diagnosis of cancer. And they have a misconception that the cervical cancer is a fatal diagnosis. And of course, vaccination, screening, diagnosis, the fourth pillar is the treatment. You can think that, okay, I have vaccination in the country and screening and the cervical cancer will finish. No. Without treatment, you can never eliminate the cervical cancer. First of all, even if you start today, the vaccination and screening, still in the next 2 decades, you will have lots of patients, especially coming from the screening, who will need treatment. On the other hand, if you see here, the stage at the diagnosis is really prognostic. So the waiting time for the diagnosis and treatment of the patients should not be longer. You see some benchmarks. Usually they are 2 to 4 weeks to have a diagnosis, to have a treatment. But you see again, high income, low income, and medium income countries. We are talking about the same patient, the same stage of the cancer, and the survival differs. In one country, it's 70%, in another one, it's 95%. So you should invest on treatment too. You should invest because this is the WHO program, and without investing on treatment, you cannot rapidly eliminate the cervical cancer. Just with vaccination and just with screening, it takes around 100 years to eliminate the cervical cancer in one of the African countries. But with adequate treatment, it can only resolve in 40 years. So it's very rapid, and you can prevent additional 300,000 deaths. But, you know, the situation is so difficult. At the end, when you are talking about the cancer treatment, you have the surgery, chemo, radiotherapy, and pathology. And as you can see, this is the low-income countries, this is the high-income countries, around 5 times more access to treatment. Especially, please see the radiotherapy, it's around 16%, almost zero. The same figures are also true for chemo, for also pathology services. Surgery is important. I want to share some important numbers, you know, very, very, really advocative, very provocative numbers. Less than 1% of the individuals in lower income countries have an access to surgery. This number is unbelievable. For example, in sub-Saharan Africa, 90% of the cases have just one operating theater per 100. Even in great majority, you don't have any water, you don't have electricity, you don't have any pulse oximeter. These are the realities of the world, my friends. Not everybody is in a developed country. For cervical cancer, again, just to give you another provocative number, for a cervical cancer surgery, you need surgeon, you need anesthesiologist and obstetrician. So this is so-called provider density. This is less than 1 in Africa, in low-income countries, and is around 60 times more in the developed countries. This is the main controversy. And immigration. Unfortunately, even if you have some skilled and trained surgeons, they do not stay in their home. So, surgery, centralization, again, a problem. The cost, the transport of, they don't have the money to come to the central countries. Poor referral networks, the infrastructure, trainings, and the fear of the patients are the main challenges. In the treatment, radiotherapy has also lots of challenges, but please do not forget, you cannot treat cervical cancer if you don't have radiotherapy. Cervical cancer is so unique, yeah? You see the survival benefit of radiotherapy. In many cancers, you don't even need radiotherapy. But it's a cervical cancer and head and neck cancer. You definitely need radiotherapy. And radiotherapy is not a device, something like that you put. You need a radiation oncologist. You need a medical physicist and a radiation technologist. Of course, we have some bench numbers. For example, for 500 patients, you need at least 1 medical physicist. For 300 patients, you need at least 1 radiation oncologist. It's not only a device issue. And from the device, of course, in the Africa and in low-income countries, the International Atomic Energy should find some solutions. Because, for example, if you look 140 low-middle-income countries, it's only 4 countries that can meet the need of the external radiotherapy. Unbelievable, really very important discrepancies. So we have challenges in radiotherapy. The cost, the multidisciplinary team, the differences in the rural and transport area, problems in the maintenance and imaging technologies is a big problems. So my colleagues, my friends, the 5th pillar is the palliative care. Even if you don't do anything for these patients, no surgery, no screening, you have to find some types of palliative care for your patients. You will ask, what is this? This is a new word, and based on opioid usage for pain, for cancer pain. As you can see, the majority of the world is now USA, Canada, and Australia. In almost a great majority of the cases, we don't even treat the pain of our patients. So this is something that we have to talk, because at least minimally, you should have some palliative care. You should work and fight with the misconceptions that the palliative care is the terminal stage. You should fight with the fear of opioid. You should fight with the sociocultural cultures. And you should say that this is a human right. Without palliative care, this is something like water. This is something like air and health. Having a palliative care system is really a human right for lots of us. Then the others come, of course, opioids, oral opioids, staff training, personal training, home-based treatment, caregivers, the rest will come. But first you should understand that this is a human right. And my unique suggestion actually for the whole world is the resource stratified guideline. So depending on the budget, depending on the resources, we can really have a resource stratified. It's not only necessary that you need a surgery. Sometimes you can have a small brachytherapy to start in some countries. In some countries, you don't have any radiotherapy. Then you can have some chemotherapy followed by surgery. So we should be flexible in the elimination program and try to give some time for the countries to solve all these challenges. My dear friends, thank you so much for listening me, for your attention. We know that much could be done before us, much should be done with us, and much will be done within the next generations. Thank you so much, my dearest friend, dearest Sarah, for this nice opportunity to be here.
Thank you, Murat, for being here. And I always love hearing you talk. It's amazing. You always give such a great overview. And I'm very interested in the point you mentioned about palliative care. And I will get back to you and ask you at the end, but in the interest of, if that's okay with you, Murat,
Yes.
in the interest of time, I would move on to Dr. Kaufman, who's going to update us on the HPV projects that are currently going on at the Charité, and which obviously ties in very nicely with your talk. Dr. Kaufman, go ahead.
Okay, thank you. I'm trying to share my screen. So, do you see one or two slides now? Sarah?
We're still seeing you. You haven't shared your screen.
Oh. So. Teilen. Okay. Now?
Now we see the slides. Perfect. We see all of your slide overview. So.
Okay, I'm going to the presentation mode now.
Perfect, yes.
Okay. So, what I would like to share with you is the different HPV screening projects that we have performed in the last couple of years in the clinic for gynecology. My name is Andreas Kaufmann. I'm a biologist. I'm working as the head of the laboratory for gynecologic tumor immunology and HPV. And we do HPV testing for diagnostics and for clinical studies. You have just seen this slide from Murat Gültekin, giving you the incidences of cervical cancer all over the world. The southern hemisphere is hit by this pandemic. It's another pandemic that we are facing. And the numbers gives you the approximate incidence rates in the different countries that I have circled. And these countries are in sub-Saharan Africa, countries where we have been or are active in studies, but also in European countries, of course. So what is our aim? Our aim is to find adequate methods, because each country, each situation, each healthcare system has different needs. We would like to show the feasibility of the right methods to use in these healthcare systems, and then inform stakeholders about the measures to take to introduce cervical cancer screening. Also, this you have seen, the goal is to eliminate cervical cancer. That means to lower the rate to 4 in 100,000 women per year worldwide. And you also have seen already the numbers of 90% vaccination of all girls, 70% of screening, and 90% of treatment. What I would like to emphasize is that we need for that a high precision test. A high precision test that gives us the information who of those women who is infected with HPV really needs treatment and what type of treatment. And come to that later again. So what is the special situation in low resource settings? Also, this has been told by Professor Gültekin already. There is no screening programs established yet, so you have no infrastructure to build on. Cytology capacity is marginal, it's subjective, training intensive. Colposcopy is not available. Even in Germany, at times it's difficult to get an appointment. Quality controls issues are always given, especially for HPV tests, which are PCR based and have a very high risk of cross-contamination of samples. Populations are difficult to reach. financial burden, knowledge of disease is not given, knowledge of the epidemiology of HPV is not there, and there is no acceptance, or there are cultural barriers. So WHO proposes now to start with HPV testing everywhere. However, this is sometimes neglecting the prevalence of HPV, and I come to this with an example. I have doubled some slides in French. I will not go into these slides, but they just give you the same information in French when you look at the presentation later on. So I would like to start with our initial program that we had in Ghana that ran from 2015 to 2018. It was a clinical partnership between the Catholic Hospital Bator in Ghana. It's about 1.5 hours east of Accra, and Charité Universitätsmedizin. And the title of our proposal was Screening by Self-Sampling in combination with a low-cost HPV and biomarker assay to detect cases that need treatment. And this was situated in a rural region. We called this accessing because we wanted to access the women in Ghana in rural areas, and we had several very supportive collaboration partners. So the North Tonk district where Bator is situated is on the banks of the Volta River, and it's partly developed, but also a very rural area. And these 3 persons were the key stakeholders that helped us. Foremost, Dr. Kofi Effa, the gynecologist in the hospital who visited Berlin. We came to know each other, we made friends, and we started the program in the Catholic Hospital Bator, which was founded by a Dominican nun who had built up a beautiful, well-organized hospital. And it was supported by the German Rotary voluntary doctors, where Dr. Siebert was a representative. So we traveled there to appraise the situation. And what we found was what you all know in the developing countries. It's very difficult to cross a river. The Volta River is a huge river, and it's a real geographical border in the country. The gynecology ward is flooded by women, especially at market days. The laboratory was equipped with some very fancy machines and devices, but they were packed. They were never used because there was no need for them. You need the adequate method, simple tests to establish and to run in such a lab. And we have then put in an infrastructure that allowed for HPV screening. And this philosophy I really liked a lot. Our patients are queens and kings, and this should be something that global health puts on its headline. So what I also learned then was intercultural communication can be difficult. Although we both spoke English, sometimes the words were interpreted differently, and this could pose sometimes a problem. And this is also a topic of global health, of course. So our approach was to have these self-samplers handed out to women in rural communities, and then collected again by community health workers. And they came to the lab, to the local lab, and then their very simple test was run to detect the risk of cervical cancer, because the woman would have HPV and would have the biomarker oncogene expression of HPV that tells about dysplasia. We were very lucky to have a very successful program in these 3 years, and several theses and papers arose from them. But what we really achieved is actually on the next slide. So during the study, we screened 2,000 women and collected the samples in only 8 weeks from very rural communities, 5 hours away. Really, it can work. That's what I want to present to you. But we found a Hpv prevalence of 32%. And these women were mean age 36, so they were not very young women. 32% Hpv prevalence means an Hpv test is not really informative about someone to screen or not to screen, because You know, you cannot just triage every third woman again. I do hear another voice there. Okay, so we found disease, it was treated, but then we also saw that the compliance to travel to the hospital, 5 hours, 2 days or so, was not really high. But what I want to point out is after 2018, we drew out of the program, the funding had ended, and due to some misunderstandings, intercultural communication issues, I would call it, we stopped the collaboration. But since then and until now, until today, this center in Bad Tor still does cervical cancer screening, has evolved to a training center for community health workers and nurses for screening and treatment. And this is the main outcome that I see, that we initiated something, we had ideas, and we started a collaboration, we established a lab, and then we pulled out. And now still there is a sustainable system that runs and that grows, and all over Ghana now community health workers are informing about cervical cancer, motivating women to come for screening, and the hospital is prospering of that. Now, let's move on from Ghana to the current programs that we have. This is again clinical partnership, and we have 2 clinical partnerships with Casablanca Hazard University, which was the first one we started in 2017. It has been successfully finalized. And what we did there, with the help of the German Ministry of Education and Development and the Ezekulma Foundation, was to get in contact, to have mutual visits of the gynecologists from Berlin to Casablanca and vice versa, to appraise the status, to discuss the collaboration, to sign agreements between the universities, and then to develop SOPs and transfer SOPs, actually the PARSGO SOPs, to the gynecology ward of Casablanca University. We gave some infrastructural support. We have still today regular online tumor meetings established, which is a quite sustainable communication tool. Some of our collaboration partners were able to visit international and national congresses, giving talks, listening to talks. And hospitation exchange, unfortunately, was not that well organized, so we had some problems there, but we are still working on that. Now, building on this clinical partnership, we won a second grant to extend what we did there to other universities in Morocco, and to extend it also to other departments like the radiation therapy department. Now, due to the COVID pandemic, this is on hold in the moment, but we hope to start very soon again. And also both of these clinical partnerships were the basis to start i-STARC as a tool to do capacity building, teaching, webinars, and so on, what we are just doing now. So this is the same in French. And in companionship to this clinical partnership, we performed a study where we, a pilot trial, let's say, where we looked at self-sampling by Moroccan women for cervical cancer screening. Again, it was supported by the university, Lala Salma Foundation, and the Cancer Center. And the aim was, again, to show the feasibility to access women, to motivate them to come to visual inspection with acetic acid and self-sampling for HPV testing and a biomarker test. And we selected they were eager to contribute these 8 centers of health, so health centers in the area of Tanja, where 200 women were recruited to take the self-sample. We had, in addition, 20 cancer patients from the cancer center. And these samples were then analyzed by our different methods that we had established in a lab in Hassan University. I was very happy, or we were very happy to see that all who participated in the study really did self-sampling and evaluated self-sampling as a tool they would like to use in the future. Again, French slide. The Hpv types we found, first of all, the prevalence was nearly 12% in these 200 women. So again, it's a high rate of Hpv prevalence. And we had found about half of the cases were Hpv 16 positive. So the most aggressive and carcinogenic type is very prevalent. Of course, this is a very small number, and it's just a hint that Hpv typing should be done. What we then did also is to compare VIA with the biomarker test OncoE6. And here the VIA was the standard of care and the proposed screening tool by WHO then. What we found were 30 women testing, actually 31 women testing positive by VIA by the nurses in the health center, while with the self-sample and OncoE6 test, only 5 tested positive. That means that this difference is very important. That means that the VIA detected 6-fold more cases than the biomarker test. Now, all the VIA detected cases were, except for one, were negative. They had no disease. Some had not even had an HPV detected. So these were false positives. They flood the system, they flood the triage, the colposcopy, the treatment system, and it's very, so this cheap method of VIA becomes very expensive in the, because the specificity is low. In contrast, the OncoE6 test, when positive, really detected SYN lesions. We only had SYN1 lesions in this study that were 16, 18 positive. This is a characteristic of the test. In total, the histology of all these women showed that there were 10 SYN1 lesions and all were HPV positive. So just again to emphasize, the cheap method can become very expensive when it has a low specificity, and you need a high specific precision test to find these women who really need treatment. So this was then the screening rate in Morocco, which was around 12%. What do we need? We need to increase offer acceptability and participation in screening, and at least one in a lifetime HPV testing, best with a test that is of high precision, not only detecting HPV, but also biomarkers. And this is where my lab comes in. We have developed a test with all that we have learned from the problems in the low-income countries and the high prevalence of HPV. We developed a test that includes, in addition to HPV, also biomarkers. And these biomarkers of the cells are informative about the dysplasia. We have tested this, our test, QuantiGene we call it, QG, and risk score biomarkers. We have tested those and compared to liquid-based and pap smear cytology in Germany and different PCR-based and hybrid capture 2 HPV tests. And as you can see in the specificity sensitivity comparison, cytology, and this is field cytology, is very questionable in Germany with only 40% sensitivity, but the PCR tests have a very high sensitivity, but the specificity is questionable, so you have a lot of false positives. With our biomarkers included, we have the best balance between sensitivity and specificity and would find the right women who need treatment. And we were able to use this test in a study in Ethiopia. This is the Butajira area where a study was done comparing, again, participation in VIA with participation in self-sampling and HPV testing. So as you can see, going to a doctor, exposing herself to a doctor is something that is not very welcomed by women. Only 50% participated, while taking a self-sample at home was much more acceptable. And also the adherence then with 65% was much better than in the VIA arm. Now we looked at the HPV arm in more detail. And this is a complicated slide I walk you through. 1,200 women were sensitized for participating in the HPV self-sampling screening. Around 900 really participated, of whom we got 157 high-risk positive patients. So again, this is a high prevalence of more than 20% in the screening population, meaning all of these have to get a triage. We offered as triage VIA, so these women had to come to the health post, got VIA. And in this situation, another sample was taken, 110 so-called SynPrep liquid cytology samples. And these samples were again HPV tested. And what we found, somewhat surprisingly, only 26 of the 110 were still high-risk HPV positive. The others had lost HPV in the meantime between the test and the triage situation, which took like 4 to 6 months. Yeah. So there is not a lot of persistent HPV, which means there's not a risk of cancer development, but there's a lot of HPV that has to be triaged. These 110 samples were also subjected to our test, and we found only three samples that tested positive. These women were invited to VIA and colposcopy, and the colposcopist found exactly 3 women who had signs of disease. And these 3 women from colposcopy were exactly those 3 women that had been tested positive in the quantigene assay. Just for comparison, what does it mean? It means you reduce screening by 1 into 300 if you use the quantigene, the biomarker test, instead of an HPV test. And you reduce triaging by 1 into 50. And this means a lot of less burden for the healthcare system. So we are hoping to including this new assay in studies in our target countries. I talked about Ghana, I talked about Morocco. Now another program, and Ethiopia, another program is starting in Uganda in cooperation with Charities, Nephrology Intensive Care Department, and a 5th program in Tanzania in cooperation with Basel University, where we always want to access women for screening, women living with HIV, and trying to define the infections they have, HIV, HPV. All is, of course, hampered by the COVID disaster that we are all facing. So in conclusion, I wanted to show you that we have activities in diverse countries and cultures, and this makes a difference for the approaches that we have to choose and that we have to implement. We try to do a lot of capacity building to make the system independent and of our support. And we think that we don't have a one-fit-all solution for all countries. We have to respect the local differences. HPV testing alone, in my opinion, may cause problems. And as a side note, even in Germany, where we just have introduced HPV primary screening, we see problems to give service, colposcopy service to all women who need it, because we don't have that many colposcopists anymore. And as a final point, collaboration is crucial. Collaboration with the partners there, of course, it has to be their ownership of the program, and collaboration with industry, with stakeholders, with WHO. We all need to pull together on the same, into the same direction. And with this, I thank you, and I would especially want to thank our colleagues in the countries where we are active for the cooperation and continued support. Thank you.
Thank you very much, Andreas. This is a great talk. Actually, the project that you did in Morocco, this is how i-STARC kind of came to be, isn't it? We built up on the partnership that you had with Morocco and built on that and built the i-STARC community. So I'm very happy. One very quick question, Andreas. So in Ghana, you screened 2,000 women in 8 weeks.
Yeah. Oh, we collected the samples. We collected the samples. Then we had a lot of samples and had to work with them in the lab, and it was overflowed. So it took longer than we thought. Yeah, sorry.
No, I meant this is great. You know, 2,000 women in 8 weeks is a good number.
It is a good number. Actually, I have to admit, I found out later that our collaboration partner, Dr. Effa, paid the community health workers extra for each sample collected. And so within these 8 weeks, they made another year salary income by collecting. So it's a strong motivation.
Yes.
It was, of course, completely against what we wanted to do. We wanted to do it in the system with no extra motivation, to show it works. But so we had to, pay a lot for that. But it showed the logistics can work.
Yeah, it shows the logistics can work, and when there's motivation, when there's the will, there's a way.
Always, yeah.
Always, okay. We have a few questions actually from the audience, but if that's okay, I would move on to Nora's presentation, and then we'll go into the questions afterwards. So thank you again, Andreas. So Teresa Norris is from HPV Global Action, and I'm actually very pleased that we will soon announce an official collaboration with HPV Global Action, and Dr. Rosberger is here on behalf of Teresa Norris today, and will also be available to answer any questions and to maybe say a few words about HPV Global Action after Teresa Norris's presentation. So she's recorded it because unfortunately she can't be with us this afternoon, and we'll play the presentation. Enjoy.
My name is Teresa Norris, and I am a sexual health specialist, and I'm also a proud founder and president of HPV Global Action, which I've been presiding over since 2006. You can see more about our organization at www.hpvglobalaction.org. And today I'll be addressing the HPV pandemic. Yes, I did call it a pandemic, and I think that it's quite fitting. Right now, if we were to compare it to COVID, I would think that there's many similarities. And I think that the more we start focusing on HPV as a pandemic, maybe this is going to be the shift in the mindset that everyone needs to have, so we can focus more heavily on addressing the needs that are required so that we can eliminate cervical cancer. I'll be giving you the perspective of an NGO. And an interesting place for me to start my presentation, which on any other day, I have high doubts that I would start it the way I am today. But today is not just any day. Today's a special day. What you're looking at right now is a picture of my best friend and I, back when we were only 14 years of age, and we lived all those important milestones that best friends live, including participating in my best friend's wedding. And also, I'd have to say, I got to accompany my best friend through health and sickness, as when my best friend was only 23, she was diagnosed with HPV, and quickly it escalated into cervical cancer, and she was gone from the day she was diagnosed till the day she died in 7 short weeks. And unfortunately, my best friend passed away on my son's first birthday on May 11th, 2001. And today, why it's a special day is because it's her birthday today. In fact, my best friend would have been 45 years old today, and she's now gone 20 years. But this is also the prelude to how we are all sitting around here watching a presentation from HPV Global Action, because her death propelled me to do something about HPV. It was really the reason why we focused on what HPV does to a life, because of what HPV had done to my life. We really are about connecting, empowering, and implementing programs, not only in our country, Canada, but globally. And our mission is to raise awareness of inclusive, positive sexual and reproductive health through the implementation of comprehensive education programs, while emphasizing HPV and its potential consequences. We empower culturally and ideologically diverse youth, families, and communities across the globe through the dissemination of critical evidence-based knowledge. What we do and what we're advocating for, well, firstly, we're at the forefront of developing comprehensive sexual and reproductive health tools and programs that are designed to enhance and assure positive sexual health outcomes. We connect with academic settings stemming from primary schools all the way to university settings, with adults, parents, healthcare professionals, and communities of all demographics. Our current focus is on bringing national and international leaders together so that we can be communicating and providing solutions regarding worldwide HPV prevention and cervical cancer screening policy challenges, because each country has their own challenges. Here's just a bird's eye view of how we're doing our advocacy messaging within our own organization. We are lucky to have an incredibly talented vice president along our team by the name of Dr. Z. Roseberger. And he is a clinical psychologist and leading Canadian researcher, primarily in the area of psychosocial oncology. He has a team of wonderful research as well that are really looking at the best ways of communicating HPV messaging and using behavior science in our ways of communicating to make sure that the way we talk to people really resonates and creates behavior modifications as a result of them understanding what HPV has to do with them. You can see these materials, both our posters and our pamphlets, that have now been translated into 7 different languages, and we're not done yet, on the homepage of our website. So in recent years, we expanded our mandate to work outside of Canada as well, and we created what is referred to as the Green Report, called Canada's Role in Accelerating Global Elimination of Cervical Cancer. So we were a group of Canadian experts who wrote 105 recommendations for achieving cervical cancer elimination goals in Canada and in the developing world. And we really covered the full gamut of everything to do with HPV, from prevention all the way to diagnostics and treatments. And we were sure to include in our team of experts people that not only had in-depth knowledge of what was happening within Canada, but also had an in-depth understanding of what's happening in the developing world. And we outlined in each of the chapters the key barriers to all of these issues, and also recommendations to address these barriers. And each country could benefit from looking at our report to see that there may be solutions that would work in our countries. This is also a report that's downloadable on our cover page of our website in both English and in French. So further to this, the update in Canada's position for our objectives both nationally and internationally are, unfortunately, the prevention of cervical cancer is even uneven within Canada. You would think that in a developed country like ours, where we have full access to vaccines and screening programs and state-of-the-art treatment and immunotherapies, that we would be reaching these important targets that the WHO has put forth. But no, even here, we are having issues. So to achieve the goal of being on the path by 2030 of eliminating cervical cancer, we are going to have to establish innovative approaches together with community groups, like ours, and leaders in different demographics to make sure that cervical cancer elimination is a reality in communities that have a higher rate of disease. There's one thing I would highly suggest as the main takeaway for countries and areas where they're looking for new ways of creating great communication with the general population, is to really take a look at these community-based groups and leaders that have a different type of access to the communities and have tapped into a way of communicating in ways that their community understands. And this is an important tool that I think even in Canada, we would benefit far more if we had people in non-for-profits sitting at the table of the decision makers and the policy makers. It's not something that we should be asking community groups to help with at the end of something being put together, but should be at the table creating the strategies that are being put forth in areas and in countries everywhere. So our group, after publishing our green report, made a very ambitious plan implementation program to have simultaneous screening for cervical cancer and female genital schistosomiasis, which I will refer to as FGS from here on out. Before I get into that, and I'm sure some of these numbers are really not going to be surprising to any of us on this webinar today, we know that there's approximately 570,000 women diagnosed with cervical cancer around the world. This is an old stat from 2018, and I would be surprised if it has moved a lot, and I would not be surprised at all, unfortunately, to probably see that that number is rising. And unfortunately, among these, more than 300,000 women will die. And unfortunately, we are seeing that 90% of those women live in low and middle income countries. Now, further to this, we have FGS. Up to 56 million women in sub-Saharan Africa will have this. And millions of young women in sub-Saharan Africa are at risk of FGS, HIV infection, and cervical cancer. And the prevalence of FGS is underestimated. Now, today isn't the time to be getting into the details around FGS. In a nutshell, this is an endemic problem. And people around the world in developing countries are coming into contact with schistosomiasis because of water and open water sources and rivers. And luckily this year, as much as last year was the year that we adopted the cervical cancer elimination strategy, well, this year is the year that neglected tropical diseases are the focal point of the WHO. And female genital schistosomiasis is something that we're not talking enough about. So we found it an interesting coincidence that there is this marriage of two different issues that we have a very important opportunity to do something about simultaneously through our screening program. So what we're planning on doing as one of our current objectives to support the WHO's global strategy to accelerate the elimination of cervical cancer in lower and middle income countries is to go over this briefly. The 90% of girls need to be fully vaccinated with the vaccine, HPV vaccines, by 15. We would hope that we can attain a 70% of women screened with a high performance test by the age of 35, and then again at 45 years of age. And then third, to have 90% of women identified with cervical cancer disease and treatment, and so that their precancerous lesions, low and high grade lesions are being treated, and then that 90% of these same women with invasive cancer are managed with palliative care. So in addition to these objectives, there is insufficient research on efficient treatment for FGS within the sub-Saharan African context. Therefore, we are also focused on the following recommendations. Number one, in endemic areas, the WHO and the UNAIDS recommend that diagnosis of FGS is done during routine gynecological examinations, such as cervical cancer screening. 2, that effective prevention and treatment strategies for schistosomiasis may support HIV prevention. And 3, public health interventions should be integrated into other healthcare programs. We've started developing a lingo where it seems like this marriage of opportunities to have HPV and FGS and HIV all together. It's almost as if FGS has finally found that big sister that it's been needing, so that we can actually take FGS and put that kind of screening on the map. It makes full sense to be doing dual screening for women, because lesions to the untrained eye may look very similar and may not be treated or diagnosed accurately. And I think this is something that we're moving into a position where we will be able to have more accurate screening and then treatment options available. And we're in turn going to end up finding out probably much more about endemic areas of schistosomiasis. So in an effort for us to realistically maximize HPV prevention, cervical cancer screening, and treatment, and FGS, created an all-inclusive HPV faster approach, which is 1 dose of an HPV vaccine for women ages 25 to 45, and then those same women will have an HPV self-sample, and they will also then have their standard of care offered to them through VIA-Vili, and then they will have treatment for their low-grade or high-grade lesions, and then there'll be follow-up visits and treatment at 6 months and at 12 months. And then the same thing applies for the screening of FGS, that there will be a screening and treatment of these lesions at the first appointment, and then 6 months and 12 months later as well. We plan on doing operational research, starting with carrying out an acceptability study in collaboration with partners on site right before the training and at the end of the implementation. We are exploring the use of deep learning technology that could be integrated within this model for cancer screening and triaging to eventually include screening of FGS. Of paramount importance to us will be to prevent the spread of COVID-19 infection during this project. And measures will need to be taken to prevent transmission, including not starting any of our projects until we feel that it is safe, that we can protect people that are going to be participating in our project from contracting COVID-19. So the simultaneous screening has 2 goals. This will require a multidisciplinary approach with medical knowledge as a solid base combined with the possibilities of information technology. And secondly, in order to maximize prevention efforts, joint screening of cervical cancer and FGS should be the new standard of care. This should be something that should be combined and implemented everywhere. This model will be piloted with the intention of expanding and scaling it up in several countries where cervical cancer and schistosomiasis are both endemic. My colleague, Dr. Zia Rosberger, is in a position to answer any questions you may have about the things that we just discussed here today. I invite you all to go and visit our website to learn more about our projects at www.hpvglobalaction.org, or to read and download our green report, or use any of our posters and pamphlets that are in a multitude of languages. And I'd like to thank everybody for your time. And I'd like to end by saying we are happy to be collaborating with the Pan-Arabian Research Society for Gynecologic Oncology. And we are really looking forward to using these platforms to teach and expand our knowledge so that we can really make headway on achieving these WHO goals of eliminating cervical cancer.
So thank you very much. Sorry. Yes, yeah. So thank you very much. This was such a touching and relevant presentation. And really, this is when we had our first meetings with Teresa and with Zeeb and Andreas, we really saw that there is such an overlap and so many synergies between PARSGO and the i-STARC project and HPV Global Action. So Dr. Rosberger, do you want to introduce yourself and maybe say a few words on your role in HPV Global Action and make a few comments?
Well, I'll keep it brief because I think, can you hear me okay?
We can,
Can
yes.
you? Okay. I'll keep it very brief. I'm actually working with Teresa and I'm on the board of directors of HPV Global Action for quite a number of years, but I'm also a senior investigator at the Lady Davis Institute for Medical Research here in Montreal at McGill University, and have been for many decades. And yes, I started my career in psychosocial oncology and developed programs and specialized in gyne-oncology. So I've seen patients across the trajectory, but focusing now more on prevention and HPV prevention, vaccine uptake, and screening. And I think what Teresa pointed out is that while we talk about large populations, it really boils down to the individual, and her story is a very touching one. So we continue to advocate and to try to bring partners together, and I think this is what Teresa said, partnered in terms of education and developing not only research but implementation projects, operational projects to sub-Saharan Africa by bringing partners together. And that's where we feel in the future we'd like to continue working with you folks and with other folks, with Dr. Gultekin perhaps in Turkey and others, meeting these people for the first time. So this is a wonderful opportunity.
Yes, Steve, so absolutely. And I think there's a lot of potential there to actually do some good. We have a question from one of our medical students who's very enthusiastic and involved in the i-STARC and PARSGO project, Nikki Katsara, but I also know she's also involved with you guys, so small world. Nikki, do you want to ask the question live? We'll just unmute you for a second. Hi, Nikki.
Hi, can you hear me?
Yes, we can hear you. Go ahead.
Okay, perfect. Dr. Rosberger, it's very nice to see you again, Dr. Sahouli and Dr. Nasser.
We haven't forgotten about you, Nikki.
I haven't forgotten about you either. Yeah, I was actually wondering, and I think it would be also very interesting to all the attendees and also to further medical students that can listen to us at the moment. How could we get practically involved on site in the project, in the very interesting project you have going on with deep learning? How could a medical student or a doctor in training get involved in such a project?
Who are you directing this to?
To you.
Oh, to me. The part of our project that we are collaborating with others at the moment, and this is still in process, so I'm not really at liberty to discuss it too much. I don't know what opportunities there would be, but if things go as we think they will, there will be academic, I think, opportunities for medical students and others to begin to collaborate with some of our colleagues at different institutions in the States and elsewhere in some of these new technologies, and to bring these technologies to the fore. So we'll keep it in mind for sure. It's a great opportunity. We're just not quite there yet.
Well, maybe I can add to that. One of the things we're also discussing with Teresa is obviously if our collaboration and our partnership develops, then this is also something that we can work together to build. Definitely through the PARSGO Society and i-STARC Society. So you can start by registering to both and getting involved. Yes,
And Dr. Nasser, and maybe that can be a topic even on the summer school.
Yes, absolutely.
And how to create working groups and how to bring it really in clinical steps.
Do a structured algorithm for all these networks. Absolutely. Yes, thank you, Professor Sehouli. We have one more question, and then I think in the interest of time, we will say goodbye. But one more question from Dr. Ezra, and this is to all the panelists. So to Murat Gültekin, Andreas Kaufmann, Dr. Rosberger. Dr. Ezra, we'll just unmute you for a minute and you can ask your question.
Thank you very much, all of you. It was a pleasure to learn and keep learning, thanks to the PARSGO in the field of gynecologic oncology, and greetings from Istanbul. My question is that one of the experts actually touched that point, but I would like to bring it up because I really wonder your opinion about the do it at home HPV kits to overcome the challenges caused by for example, transportation issues in the African countries, including my country, and looking at the women are working and maybe they don't have time to go to the hospitals and go through all of these timing issues. And to the best of my knowledge in the UK, this project being going on, and it's the results are being promising, and also patient satisfaction rates are also good, I think. And I was wondering your opinion if this can be the solution, and also if this can be the standard of care in the near future. Thank you very much.
Murat, go ahead.
Yeah, thank you so much, Esra. So nice to hear from you. Esra is a so brilliant young star in Turkey. Congratulations for her attendance. So proud for her. So Esra, how it happens is, usually an envelope comes to the home, and the patient, opens the envelope, and it is the kit, and this envelope is already paid back. Yeah? So she makes the test and puts the test again into the same envelope and closes it. And the cargo price is already paid by the government. So it just puts into the postal box and it comes automatically. But here there is two different methods in this. One is opt-in, one is opt-out. Opt-in means that the kit is already inside the envelope. Opt-out is you have a letter. And first you accept for a self-test and send the letter back. And once you accept the self-test, then the second envelope comes with the kit. Which is more successful? This is a debate currently. In some countries, opt-in, in some countries, opt-out. But the best thing is a nurse coming and locking the door and giving the self-test, waiting in the door for 10 minutes and picking up back the self-test. This is in all countries has the highest participation rate. So I hope it is clear for you about your question.
I'm enlightened as expected. Thank you, Hocam.
So
I hear very good birds, sounds of birds.
This is my open window here. I would like to add to that, yes, we have tried self-sampling very successfully. And actually in every sub-Saharan country we used it. It was accepted with a high rate by the women and performed quite well. So I think that's the future for screening in situations where gynecologists are rare. In the situation of Germany, the gynecologists oppose, unfortunately, self-sampling because they think they lose their customers. I always tell, no, you generate more customers because those women who do not come to your office can do self-sampling, and then they are positive, then they will come to your office. So you generate customers, but it's difficult to explain. So the other thing I wanted to stress is that self-sampling is not self-testing, because if you would give a woman a test that shows up positive, like pregnancy test would show positive, and it's a cancer test, that would be a disaster. So we always do self-sampling, but not self-testing.
Excellent. Thank you very much, Andreas, also for this.
Maybe may I ask Andreas? Andreas, I am starting a new trial in Turkey. When we talk about self-test, it's always vaginal swab. But we do have urinary HPV. And we have blood antibodies. I think a German company has
yeah, Aviris, I know this company.
Yeah, what do you think about this? The future, I mean, to give a blood sample by the males, for example, urine sample again by the males and in the females. What's the difference between a self-vaginal swab versus urine? And I also do wonder, what is your idea about self-tests in pregnancy? Is it safe or not?
The last question first. So far, the self-samplers that we use, at least, they are all also approved for pregnancy, for pregnant women. So they won't harm the pregnancy. Urine as a source for HPV testing has been tested quite positively. So this works very well. First, avoid urine, morning urine, this is important. You will get all of what is around, of course, not the targeted cervical dysplasia received HPV, but you will find women positive for HPV then. So this is an option in places where the like penetration of the vagina is not so easily accepted by women. In my opinion, and actually with the assay that we have developed, including biomarkers for dysplasia detection, we will need the cervical vaginal swab, because this is the right material we need for the detection of the biomarkers.
So you believe the urinary tests will not be useful for cervical cancer?
It will be, yes.
It will be. You also
yes. It's a very convenient sampling. It has proven to be sensitive enough to detect HPV. But once again, and I like to stress this because it's always forgotten, that in some countries HPV prevalence is very high. And if you then sample, let's say, all of the vagina and all of the vulva with a urine test, you get even more prevalence of HPV. Not meaning you find disease, you find an infection that is harmless most of the times. So we have to keep this in mind, because it could overburden the system, lead to overtreatment, lead to anxiety of the women, a lot of anxiety. And we have to keep this also in mind and try to, ameliorate these problems.
Thank you very much. So I hope this was helpful to everybody. I would like to bring this to a close, if that's okay, unless there's any more remarks or urgent questions. Thank you to all of the panelists, Dr. Gültekin, Dr. Kaufman, Dr. Rosberger, everybody who's participated. We had a great turnover. We've sent you a link to a survey to evaluate the webinar. This is really important for us, so we know so we can get your feedback, and we know how to tailor our webinars in the future for your own needs and what you would like to hear from us. So please take the time to fill them in. We've just sent it in the chat. And I would like to again thank everybody, and maybe ask Professor Sehuli if he has any words for the end. Professor Sehuli?
Ich liebe Murat. I am translating from his lips. Murat, you are super. Andreas, yes, you are excellent. Very nice.
Nobody can hear him, correct? Professor Sahuli? We'll just, for some, you're unmuted, but we can't hear you.
I'm not unmuted.
Yeah, now you are done.
Okay, I'm not unmuted. Okay, so no, but Murat translated it very good, because body language is the key point in intercultural communication. So what I want to address is everybody's talking about sustainability in global health. And congratulations to you, Sarah, and all the participants, because this is sustainability. If you continue and you grow, and even the interaction with the medical students, I love it. So I thank you to be part of this, and that's, I think, should be the next future, even for the next meetings. Happy to be there.
Very much for your support and your mentorship, Professor Sahuli. And thank you everybody for being here.
Thank you so much, dear Sarah, for the nice invitation. Nalit, Andrea, Steve, Estra. Thanks, everybody. Bye-bye.